वो हो जाएगा, just wait. We are going live. It's HIV webinar. I write correctly. Let me check. Yes, we are live.
Assalamu alaikum and a very warm welcome to everyone. My name is Malaika Mehboob and I am delighted to host today's free webinar titled as Empowering Healthcare Through HIV, AIDS, Knowledge and Awareness. This webinar is organized by MedSparkles, an institution committed to advancing medical education, research skills and community health literacy. We are grateful to have an enthusiastic audience joining us from different regions. Students, healthcare professionals, and individuals passionate about public health. Your participation today shows your commitment to spreading awareness and reducing stigma around HIV and AIDS. It is my absolute pleasure to introduce our distinguished speaker for today, Mr. Hamza Chaudhry. He is MBBS final year student from King Edward Medical University. Mr. Hamza is not only an outstanding medical student but also a passionate researcher, data analyst, and public health activist. He has delivered 25 plus presentations, worked as research mentor, and actively contributes as a peer reviewer. He is currently associated with Cochrane and Web of Science, supporting global efforts toward evidence based medicine and community health.
Assalamu alaikum, everyone. Okay, so I am Hamza Chaudhry from King Edward Medical University. So today my topic of discussion is actually HIV virus and acquired immunodeficiency syndrome. So first of all, I would like to know that where do you all belong from? Like, of what field you are actually from? Like, is it PharmD, MBBS, DPT? So that I may keep the lecture relatable to you guys, so that you may relate it in your field. So, actually, what is HIV? Do you have a basic knowledge about it? If anyone has, please start writing in the comment box what is HIV and what is your basic knowledge of AIDS. Like, what is acquired immunodeficiency syndrome to you? Next slide, please. So let me start with what is HIV. It is a virus. It is it belongs to the group of retroviruses. Retroviruses is a group that uses reverse transcriptase enzyme to replicate the DNA into the into the most into that form so that it may integrate into the human cell. So retroviruses is a group of viruses, and there is a subgroup in the retroviruses which is known as lentivirus group, and HIV belongs to that group. Now we have to talk about the structure of HIV virus. It is an RNA virus. It contains two single copies of positive sense RNA. It is enveloped. Now the word here enveloped is very important because whenever the virus attaches to the cell through the receptors, it leaves its envelope outside and only the nucleic acid goes inside. So that is why I discussed like three important things about HIV here. Its structure, which is the enveloped RNA virus, and it contains two copies of single-strand positive sense RNA, and also third thing is the enzyme. So it contains an enzyme termed as reverse transcriptase. Now there are two antigenic types for HIV. One is the HIV type 1 and the HIV type 2. The more common one and the worldwide is actually HIV type 1. So when we talk about human immunodeficiency virus in our clinical setting, whenever we see a patient being HIV positive, so the antigen with which he or she is most likely to be like infected with is going to be the HIV type 1. And HIV 2 is not that much transmissible, it is not worldwide, and is only found in West Africa mostly. Next slide, please. So now we have to discuss about the modes of transmission, because if we do not know about the modes of transmission, how are we able to prevent it? And if we do not know about the structure and pathogenesis of HIV, how are we able to treat it? So that is why modes of transmission is very important. Now let's start. It is going to be transmitted by the exchange of certain body fluids. We all know like sexual contact is very important because it is very like it is widely documented as well, and we might have heard about it in various newspapers, patents, and as well as in our online awareness campaigns, that sexual contact is very important. Even in movies, films, and like many of the documentaries, it is quite documented. So sexual contact without like unsafe sex and unprotected vaginal or even anal sex, that is the most common mode of transmission globally. If we talk about the history of HIV, like how it started and how it started like in humans, it was through the homophobic males. So that is why I discussed the word as anal sex. So it first started from monkey, as it is believed historically, then it got transmitted to male, like, and then from male to male it went on, and it like gained this much amount of prevalence in the world at this time. So it was all through the sexual contact. And then we have one more mode of transmission, that is the parenteral exposure. Now, what is parenteral exposure? It is exposure through your needles, bloods, or any fluid that is being administered to your body apart from your entron. Like whenever you give any intervention to the patient, which is not related to the gut, and the gut is not involved, that is a parenteral exposure. So if you have HIV in food, you're not going to have HIV. You're not you HIV is not transmitted in you. But if you have a syringe and you poke the syringe with an HIV patient and then you use it, so you might get HIV exposure. So there is parental exposure, and then very interesting fact about HIV is that it can transmit from mother to child during pregnancy and birth and breastfeeding. So what do I mean by pregnancy? So during the time period of 9 months, at any point, if the mother is infected, she can transmit the virus to the fetus and the fetus can have developmental problems. There can be like pregnancy associated issues, preterm labor, and intrauterine growth restriction. Now during birth, like there is the transmission, like the baby passes through the vaginal canal. So if we have lesions over there, then it can have transmission at the point of birth. And then after birth, if the baby is feeding from the mother, there is breastfeeding. So these are three important other ways by which the mother can transmit HIV to the infant. So if we see a child with HIV, like a 5-year-old child with HIV, what is the most likely thing that you're going to think about the child, that how the child got HIV? According to me, it is vertical transmission. There could be parental exposure as well, but most likely is vertical transmission if a child is having HIV, or if a child is being HIV positive. And then finally, the blood transfusion, but it is not a very common cause anymore because nowadays we screen the blood properly. Like we screen it for syphilis, HIV, HBV, HCV, and also some other important like blood-borne infections, including malaria. So we screen it properly. And without screening, we do not transfuse the blood. So blood transfusion is a cause. It can happen, but it is not very common because of this rigorous screening. Now, the important point is that HIV is not spread by air, by water, saliva, sweat, tears, or even closed mouth kissing. So, what does this line mean, and what is the significance of it? Historically speaking, people used to separate their pots and separate their rooms from their HIV positive relatives, even parents, and even children, because they had that stigma that I might get HIV if the person eats with me in the same pot, uses the same plate, or lives in the same environment with me. But now this fact is nullified, it is completely obsolete, that HIV does not transmit through air. It does not transmit through water, saliva. So HIV positive patients can live with you even if they are your family members. You do not have to isolate them. You do not have to quarantine them because there is no air transmission, water transmission. You can eat with them as well. But just remember that you should not do any of these following things. That there should be no sexual contact or unsafe sexual contact or parental exposure. Do not use the same needles as of a HIV infected patient. Or also, as a medical personnel, I would like to recommend you all to study about the needle stick injuries because they are the most common cause of transmission of hepatitis B, C, and HIV. So you should know about the SOPs of how to use needles and how to work with them and how to dispose of them properly. It is a practice. It should be like it should be common among the medical personnel because the parental exposure, it is most common among the medical personnel because they use injections, they work with syringes, and then they are just careless about it. So there is a high chance of what there is going to be high chance of bloodborne infection, transmission, and exposure. Next slide, please. So after talking so much in detail about the modes of transmission, which was very important because mode of transmission is equal to the prevention, because when we're going to prevent HIV, we need the mode of transmission. Now I'm going to talk about the pathogenesis. Its importance is that if we know the pathogenesis, we would know that what drugs we are going to use. Now, the cells of the body that are going to get impacted by HIV are CD4 positive T helper lymphocytes. Now, what is the importance of CD4 positive T helper lymphocytes? Actually, they modulate or mediate your entire immune system. Whenever you have an antigen exposure, any viral infection, any bacterial infection, it will be picked up by the antigen presenting cells. Talking about the cellular pathology or at the level of cell and at the level of immunology. So these antigens are picked up by the antigen presenting cells, and then they are presented to CD4 positive T helper lymphocytes to start the immune reaction. So they are the starters of the immune response. So if we don't have CD4 positive T helper cells, we won't have activation of B lymphocytes. We won't have further activation of macrophages. We won't have activation of further CD4 positive T lymphocytes. There is a huge cascade of how antigen presenting cells react with CD4 positive cells, present their antigen to CD4 positive, and how CD4 positive further releases cytokines to cause its own proliferation to increase it, and how it does to mediate the macrophage phagocytic response, and how it acts on the B lymphocyte so that it may produce the antibodies. It is a long chain. But the main point here is that if the CD4 positive cells are infected, they will die. And when the cells die, their concentration is going to go low, and there is not going to be any kind of immune response against any antigen or infection. So a patient with HIV is highly immunocompromised, so he or she can have opportunistic infections. Now, the pathogenesis starts with like binding and fusion. So virus, with the help of GP120, its receptor, the receptor on the virus, it binds to CD4 positive receptor and co-receptors, which are CCR5 and CXCR4. So these are the co-receptors, and CD4 is the main receptor. There's GP120 binding of the viral receptor with the CD4 positive receptor on the CD4 positive T cells, along with the co-receptors CCR5 and CXCR4. I hope you're getting my point here. And there is actually a complex of these receptors, and it causes binding and fusion of the virus. Then there's going to be an uncoating. So other receptors will come and they will uncoat the virus, and virus leaves its envelope outside. As I discussed earlier, the virus is composed of what? An envelope, a coat, and inside of it lies the nucleic acid, the protein capsid, and the reverse transcriptase enzyme. Now, there is reverse transcriptase enzyme and the nucleic acids. They all went inside a cell. The coat is left behind. So now the viral RNA, as we discussed, it is a positive sense RNA. It is having two copies of RNA, and it also has an enzyme, the reverse transcriptase. Now it is going to convert this positive sense RNA into the DNA, because human cells, they are what is the nucleic acid type found in the human cells? It is the DNA in the nucleus. So you have to convert this viral RNA into the DNA to cause the incorporation of this nucleic acid inside the nucleus of human body as to start the further replication process. So for that we need an enzyme. Like the HIV virus needs an enzyme. The enzyme is named reverse transcriptase. Now the integration, there is another enzyme that it brings along, that is the integrase. So now the viral DNA has been formed from the viral RNA. And now we have to incorporate this viral DNA with human DNA, and we do it by the enzyme integrase. And finally, there's going to be the replication. So the host machinery and the host enzymes are going to be used by this viral DNA inside the human DNA to replicate. So it will replicate, it will make its own copies, it will make more viral DNA molecules, and it will make proteins out of it, and will make long chain polypeptides. And these long chain polypeptides will be produced through the process of what? First of all, DNA replication, then transcription, then translation. All these processes will work like under the influence of human machinery, human enzymes, and finally there is going to be long chains are going to come out, and then there is a third viral enzyme protease which will cleave these and break these large polypeptide chains into smaller molecules and enzymes. So here I have discussed about the three important enzymes. One is the reverse transcriptase, one is the integrase, and one is the protease. Now why it is important to discuss these enzymes, and why is it important to discuss the gp120 receptor, or which binds to the CD4 positive receptor? Gp120 is a viral receptor. Now it is important because when we make drugs, we make targets of drugs. Actually, we use targeted therapies nowadays. So we can stop the inflammation, we can give antivirals, but now we have to give targeted antibiotics, so antivirals and antimicrobials. In the previous month, we had the antimicrobial resistance campaign, like everywhere going on worldwide. So antivirals, they should also be used with caution. So we have to use the targeted antivirals. So we make the antivirals to react against integrase, protease, reverse transcriptase, and GP120. And if we do not use the targeted antivirals, we won't have that much efficacy out of the pharmaceutical treatment. The medical treatment would be futile. It would be like useless. So we have to make proper drugs so that it is going to halt the replication process and will halt the pathogenesis of HIV, so that we can stop it at the point of binding and fusion, we can stop it at the point of reverse transcription, we can stop it at the point of integration, we can stop it at the point of replication, even at the point of assembly we can stop it. And at any point we are going to give a drug that is going to stop the replication of the virus. We can stop the progression of HIV in the body, and we can save the CD4 positive cells from dying continually. So we can stop the death of CD4 positive T cells so that they can replenish themselves and can make the person immunocompetent again. So that is the purpose of learning pathogenesis here. Next slide, please. So now we have different stages of HIV infection. So if the patient has acquired the virus, now there's going to be a stage one, which is generally it goes unnoticeable, because the symptoms in stage one, they're just equivalent to a normal flu, like a common cold. So as you can see, 2 to 4 weeks after the exposure, there's going to be a high viral load. It cannot be detected clinically and can only be done through investigations. And then there's going to be flu-like symptoms like fever, rash, and lymphadenopathy. Now, fever and rash, these are also associated with the other conditions termed as drug hypersensitivity, with the type 3 hypersensitivity reactions, and with also some other common viral infections like even EBV, CMV, which are self-limiting. And lymphadenopathy is also associated with generalized bacterial infections, common cold, as well as rhinitis and pharyngitis. So the people, actually these symptoms go unnoticeable. They're also self-limiting. They will resolve on their own, You do not need specific treatment, you only need symptomatic treatment. So while visiting the GPs, we usually tell them about our symptoms, and like flu, like fever, rash, and lymphadenopathy, and they take it as a normal bacterial infection, and they like prescribe you the medication like steroids and some other antipyretics. So but that is going to resolve this, resolve your symptoms, but not the infection which is HIV behind it. So it goes unnoticeable, it is not detected in the acute HIV stage. And then we have the stage 2 of the infection, which is the latency. Now latency is also another mechanism, or we can say the phenomena through which the viruses or the bacteria, or we can say the microbes hide inside the human body. The good examples are the syphilis bacteria actually hides inside the body before causing the tertiary syphilis, and the Epstein-Barr virus hides inside the B lymphocytes before causing the malignancies and lymphomas. And similarly, we have other examples like hepatitis B is very notorious for hiding in the body and going latent. So it hides in the liver cells through its DNA, and it cannot be eradicated. Similarly, the HIV after the acute stage can hide in the body, can hide in the CD4 positive cells by binding to the receptor, by going in and hiding in the DNA of human. So, and without replicating. So there is not going to be any viral load, low viral load. There's not going to be any antigen in the serum. There's not, serologies are also going to be negative. And CD4 positive count can also stay normal. Uh, there can be some amount of viral load which can be detected on PCR, but we will talk about that later. But they actually remain unnoticed. There are no symptoms. There is no positive investigational findings. So that is the stage 2 of HIV. And then there's going to be like the replication of the virus. If the person for some reason goes into a transient immunocompromised state, now that is the point where HIV can take advantage of the body and can start its replication. At that point, it is going to cause death of CD4 positive T cells, and CD4 positive count can also go low. It will be declined. It is going to be get declined, and we're going to have a less CD4 positive T lymphocytes. We can also have the antibody against it, antigen against it, and we can also have a positive viral load as well. Now that is the stage of active HIV replication. So initially we acquired the HIV, it hid in the body, and then it replicated. So these three things form the three stages of HIV infection. And the first stage and second stage, they do not say anything to you. They can also be as long as 10 years, and they can also go unnoticeable. So if a patient, or we can say an individual had an exposure 10 years back and presented with the symptoms of, of being immunocompromised, not having a recent transplantation or any recent use of immunocompromised or immunosuppressive drugs, we can have a suspicion of HIV there, because it can stay, it can be acquired, it can get acquired by the body and can stay in the body for 10 years and can present itself after 10 years in the stage 3. So stage 3 is the clinical stage of HIV, and the rest two, they are not the clinical stages of HIV, because there are not going to be any symptoms, any investigational findings are not going to be positive in the stage 1 and stage 2, but the investigations and the symptoms and the and the opportunistic infections, they are going to be positive in the stage 3. Also the CD4 positive count is going to decline in the stage 3 of HIV, which is also termed as the acquired immunodeficiency syndrome. And when the HIV has reached stage 3, we can call it as an acquired immunodeficiency syndrome. And here the criteria is that CD4 positive count should be less than 200, because if it is more than 200, the patient is immunocompetent. But as the CD4 positive count goes below 200, now we will be at the risk of development of what opportunistic infections. Next slide, please. So now what are the common opportunistic infections? Like they could be like, it can virtually affect any organ of the body. Here's the more noticeable are that CD4 positive count, it declines and can go below 200, can below 100, can below 50. So now above 200, a patient is not going to get opportunistic infections. Below 200, he or she may be susceptible to some infections, and below 100, more dreadful infections. Below 50, life-threatening infections. Now, let's talk about the respiratory. We are going to have pneumocystis cerevisiae, pneumonia, PCP. Tuberculosis can actually have its reactivation in the secondary active TB. There can be fungal infections, opportunistic fungal infections. You all know about candidiasis, cryptococcal meningitis, or aspergillus, even mucor and rhizopus. And we are going to have the viral infections, cytomegalovirus and herpes simplex, because herpes simplex also goes latent in the body. And when the body is going to be compromised even for a transit time, the herpes simplex will present itself again. And malignancies such as Kaposi sarcoma and non-Hodgkin lymphoma, these are the opportunistic infections that are going to be caused by being immunocompromised due to HIV. These can also happen due to some other due to some other cause of being immunocompromised. I just told you about the immunosuppressants and the renal transplantation or any other transplantation or any other congenital, you can say, immunodeficiency syndrome, which is due to genetic problems. So at any point, if you go below CD4 positive T lymphocyte count, you can have these opportunistic infections because you will be considered immunocompromised at that stage. So CD4 positive count is a good monitor for HIV, but it is not specific for HIV. Now we will discuss about the specific test of HIV in the later part of the lecture. Next slide, please. Yes, like in addition to causing the infections, HIV can primarily infect various other cells of the body and can cause systemic complications. So there is actually very worldwide famous HIV-associated neurocognitive disorders where it causes the death of neurons and can cause encephalopathy and can cause cognitive decline. And it can also infect the heart cells and can cause risk of myocardial infarction. It can also impact the vessels. It can cause accelerated atherosclerosis, causing MI, stroke, because it is going to provoke a chronic inflammation in the body as well. And there is also going to be metabolic changes associated with HIV, and there can be like direct impact on the kidney cells, kidney tubular cells, on the glomerulus, on the vessels of the kidneys, causing what HIV associated nephropathy, which is a focal segmental glomerulosclerosis. It is a glomerular disease which is going to cause proteinuria, edema, and it can also cause progression to kidney function decline, can cause chronic kidney disease, and finally can lead to end stage renal disease. So systemic complications are neurocognitive decline, MI, stroke, metabolic changes, accelerated atherosclerosis, active inflammation in the body, provoking inflammation in the body, and in renal it can cause chronic kidney disease, can lead to the end stage renal disease, and the patient can be put to renal replacement therapy just because of HIV induced nephropathy. Next slide, please. So now we have discussed about how HIV can cause disease in your body, like through the opportunistic infections, and second is the systemic complications, which are directly impacted by HIV. HIV can also cause primary tumors and malignancies as well. So this is how we can also present a patient with HIV can also present with the signs symptoms of all these complications as well at the clinic. So you should always have a suspicion. If there is an opportunistic infection, have a suspicion of HIV because it is not normally present in a normal immunocompetent individual. So now what is a diagnostic algorithm? So let's forget what is written on your screen and let's just focus on what I'm telling you. So in any sort of infection, you do these important steps in the diagnosis of an infectious disease. First is the sample taking. So you take the sample and then you go and you run the microscopy. You observe the sample, you make a smear and observe it under a microscope. Then you go and do the culture. Then you do the serology and identify the antigens and antibodies in the body related to the virus or the bacteria or any infectious agent. And then there is going to be a nucleic acid amplification testing, which is done through PCR or reverse PCR or real-time PCR. And lastly, there are specific tests, biochemical tests. So always remember, to detect any infectious agent, you have to go through these steps. And with each step being more expensive, more tedious, and less available for the poor and economically compromised individuals, as well as they are less available in the healthcare setting as well. So always remember, let's start with the cheapest and easily readily available and widely accepted test. So let's start with, because in the viral infections we usually do not go for microscopy because nothing is going to be observed in the microscopy because the viruses are stain negative. They do not stain with gram positive stains or any other stains. And viral culture is very expensive, so we do not do that as well. And sample, yes, the sample for HIV is to be serum. We have to take the sample and we can start with the serology then, the third step, because we just cancel the first two steps in the detection of an infectious agent. So In serology, you have the serum. Now you can use techniques. The most widely used technique is the ELISA, the immunosorbent linked immunosorbent assay. So enzyme linked immunosorbent assay, that is ELISA. You can use that technique. You can detect antigen of HIV. You can detect the antibody that the body is forming against HIV, or the body formed against HIV before the decline of CD4 positive T lymphocytes. Because if you have a decline of CD4 positive T lymphocytes, I've already told that there's not going to be any B cell response. There are not going to be any antibodies being formed. So if you have a detectable antibody, either it was a resolved infection or the infection in an early stage before the decline of CD4 positive T lymphocytes, because you need CD4 positive T lymphocytes and then B lymphocytes for the production of antibodies. So you can detect antigen through serology. Then the more expensive test is the nucleic acid amplification test done through polymerase chain reaction, where you can detect the amount of DNA. We can say the viral load is the amount of DNA of any infectious agent found in the specimen that we have taken from the patient, and we can detect the viral load from the nucleic acid amplification testing. We can also detect its presence and how and the amount in which it is present. We can detect these two things. So it is more specific, more sensitive for HIV. And finally, we have to go with the antibody differentiation. If we have the antibody against HIV, we also have to differentiate whether the antibody is against HIV positive or the HIV 2 positive or the HIV 1 positive. So we have to identify against which strain this antibody is positive. So, and finally, we have to go with the baseline monitoring, like the CD4 positive cell count. I've already told it is not specific for HIV, but it is good for monitoring, because if your CD4 positive count was actually, if a patient's CD4 positive count was actually 250 a month ago, now it has gone down to 150. It means that treatment is not working. The virus is resistant to your treatment, and you have to change the treatment, or there was development of resistance because you did not use the right regimen. So CD4 positive count is good for monitoring. And if the patient has a CD4 positive count more than 200 for more than 3 months, we can say that we successfully treated the infection. Although it will stay in the body, but we have treated the replication. We have stopped the replication of this virus in the body. So that is a point where CD4 positive cell count is important, because it can be used as a monitoring tool. And then finally, the viral load is also very important to detect what is happening to the virus, because if the viral load is high, the virus is actively replicating, and we have failed in our treatment. But if the viral load is low and the CD4 positive count is improving, we successfully treated we successfully treated the HIV infection, and we stopped it from replicating. So these are the monitoring for HIV. We can also do tests for the opportunistic infections. For example, for CMV, you can, for cytomegalovirus, it is CMV, and you can use endoscopy for esophagitis, because you can identify the ulcers of the esophagus with that. For lymphomas and non-Hodgkin lymphoma, and for the primary CNS lymphoma, you can go do non-contrast CT and then MRI brain. And for PCP pneumonia infection, you can do bronchoalveolar lavage, chest X-ray, and can do staining. Mucocarmine staining can be done. So these are additional tests to detect the opportunistic infections. So this is the diagnostic algorithm, and the investigations are also discussed in it. So basically, always remember, we have 5 stages of investigations while detecting infectious agent. That is starting with the specimen, then go for the microscopy, then the culture, then serology, then nucleic acid amplification testing, and additional biochemical tests. Next slide, please. So now let's talk about the treatment. We talked about the investigations, we talked about the pathogenesis, the modes of transmission, and we talked about what HIV can cause to the body and what it can do to the body. And now we have to talk about the treatment, or you can say the overall management of the patient. So in the management or treatment, we have to start with the treatment of opportunistic infections, because sometimes they can also be life threatening. And there are certain infections in the body, like CNS lymphoma and Kaposi sarcoma. They will actually go away once you treat the HIV successfully. And so we have to keep our treatment focused on the treatment of opportunistic infections, treatment of complications, treatment of systemic complications, as I have told, and specifically we have to treat the HIV infection. Now, how we can treat it? There is a new regimen started by WHO, that is the highly active antiretroviral therapy termed as heart therapy. So in the heart therapy, what do? You take three drugs. The basic purpose of heart therapy is just like TB dots. It is just like anti-tuberculous therapy in the ATT. We have to use multiple drugs to prevent early development of resistance of HIV to one drug. Because if we're only using one drug and one class of drug, we can quickly develop HIV resistance, because the HIV is going to produce the further enzymes against it, will evolve against it, and can overcome this antiviral. So majorly, we do not use one class and we do not use one drug. We use a therapy. We use three drugs, and they should be belonging to more than one group, at least two groups. So we use a nucleotide reverse transcriptase inhibitor, the NRTI, and we can combine it with one more NRTI, and we can combine with the protease inhibitor. As I've told, the enzymes were reverse transcriptase, integrase, and protease. Now you use the drugs against these enzymes. So you just not only block the reverse transcriptase, you have to block one more enzyme. So at any point, you have to use drugs with two classes, so that you can actually stop the replication of the virus at 2 points, because I told you the point is binding fusion, and there is then replication of the RNA into DNA, then there's going to be integration of the DNA into the host DNA, and then there's going to be replication, and transcription, translation, and then there's going to be the breakdown of these larger polypeptide molecules into the smaller ones by the use of protease enzyme. Now you have to stop two of these five steps. So in the basic ART, the antiretroviral therapy, we use commonly use the nucleotide or the or the nucleoside reverse transcriptase inhibitor, or we use the protease inhibitor. So basically, we target the reverse transcriptase enzyme and we target the protease enzyme, and we inhibit these two steps more commonly. We can also combine it with an integrase inhibitor. We can also combine it with a GP120 inhibitor or a GP40 inhibitor. We can also use other drugs. We can stop the other steps as well. But more commonly and worldwide, it is acceptable that you have to stop two steps, and they are going to be reverse transcriptase and protease. So this is actually the all about the antiretroviral therapy. In pregnancy, you have to use those drugs which are not pathogenic, and in pregnancy, you have to start the antiretroviral therapy as soon as possible, not keeping in view the CD4 positive count, because here in the normal individual, we keep the CD4 positive count into like our consideration, and when it is more than 200, we stop the treatment. When it is less than 200, we start the treatment. But in pregnancy, we do not care about the level of CD4 positive cells. We have to start the ART at any point, because we have to save the baby from the transmission of HIV infection. So here I have written a line that if it is going to be undetectable, it is untransmissible. So if the antigen, antibody, and majorly the nucleic acid amplification test or the viral load is very low, or even negative, it is virtually never negative, never zero. It can be low. So the lowest possible viral load, if we have it, then it is the person is not able to transmit the HIV, because if because what are we detecting the viral load in? We are detecting the viral load in the serum, and we have talked about the unsafe sexual practices, parental transmission. In every sort of transmission, in every mode, the serum was somehow involved. So if we minimize or decrease the viral load to a point that it is not able to transmit it, we have successfully recovered the patient. The patient is not able to transmit the infection anymore to the individuals he or she has a contact. So we have to use the ART to improve the CD4 positive count and decrease the viral load to a point where it becomes undetectable by the PCR machine, and it becomes untransmissible. Now I have discussed the major drug classes: nucleoside reverse transcriptase inhibitors, integrase strand transfer inhibitors, and non-nucleoside reverse transcriptase inhibitors. Add a few more to this list, that is a protease inhibitor and the GP120 inhibitors. Next slide, please. So now the clinical management and monitoring. So we have to do the HIV viral load. We have to monitor it every 3 to 6 months, and we have to assess the treatment efficacy and suppression. I have already told you that if the viral load is increasing, we have failed in our treatment. The treatment has become resistant. The virus has become resistant to the treatment. And then we have to detect the CD4 positive count again every 3 6 months. We have to take the baseline first, and then every 3 to 6 months we have to take the CD4 positive count again. We have to assess again the resistance. and we have to assess whether the immune system has developed itself or not, whether it has reconstructed or reconstituted itself or not. And finally, we have to take the kidney and liver function. Yes, we have to do the baselines of it, because HIV can surely derange the kidney function, the renal function test, it can derange that. But more commonly, the drugs that we are using, they can also be nephrotoxic and hepatotoxic. So we have to take the baseline, so that we have to assess the effect of treatment on liver and kidney. And yes, it is done for drug toxicities and comorbidities. And the lipid and glucose, because we have to assess the overall metabolic condition of the body and of the patient, because HIV can also have metabolic impacts, can cause chronic inflammation, can cause hyperlipidemia, hyperglycemia, can also lead to diabetes mellitus in some patients. So we have to monitor the glucose and lipid levels as well. So this is the basic clinical monitoring. Now, the last thing that we have to discuss today is the prevention strategies. Next slide, please. We are now onto the prevention strategies. That I told you that pathogenesis is associated with the treatment, because why do we study pathogenesis? To treat the viral, to treat the virus, to treat the infectious agent. If we know about how the virus replicates and virus infects the cell, we can stop it by using targeted treatment and targeted drugs and antimicrobials. But the knowledge of transmission and its modes is important for the prevention. So now we have to start with the prevention strategies. Yes, if the patient or the person, for example, a medical personnel, is going in a surgery, in a very high risk surgery, because in surgery, what we do, we always take the HIV serology and Hep B serology and Hep C serology, because they are highly blood-borne transmitted infections. So a medical student, or we can say a surgeon, or we can say someone who has to intervene on a patient, or has to access the patient parenterally, and is actually at a risk of exposure to highly infectious bloodborne infectious agents, he or she can start the pre-exposure prophylaxis. And or we can say that if you have an event somewhere, like a surgery, we have to perform that, and the patient is HIV positive, and you have to perform the surgery over that patient. Yes, there is a chance that you might have exposure of HIV through the, if you accidentally get a cut, or if there is a needle going through your skin, you can acquire that. And for that, we have to start the pre-exposure prophylaxis for the medical personnel, most specifically. So we have to do the daily medication till that event, which is the Truvada. It is a brand name for the nucleotide reverse transcriptase inhibitor. And it can surely prevent the infection, because starting from the starting point, we have to uh, take the drug, and till that event we have to continue the drug. Now, in the post exposure prophylaxis, now what happens if a medical student has accidentally uh, got the needle sticking into the skin, and has exposure of HIV. Now, what does that medical student, or that medical personnel, or the nurse, or the staff do? What they have to do? They have to go into the for the post-exposure prophylaxis. There is no vaccination for HIV, so only thing we can do is post-exposure prophylaxis. So if the ART is taken within 72 hours exposure, and it has to be taken for 28 days, it is efficacious, and we can do the post-exposure prophylaxis through the antiretroviral therapy, but it should be taken within 72 hours and should be taken for 28 days, so as to prevent the viral replication in the body, viral fusion and binding and replication, so we can stop that. And finally, there is going to be treatment as prevention. Viral suppression prevents transmission to partners. So if a patient is already HIV positive detected, and it is and diagnosed with HIV positive, so we can give him the medications, for example, the antiretroviral therapy that I have just discussed, and we can suppress the viral load to a point that the patient becomes not a reservoir of the infection, and is unable to transmit it to other individuals he or she may have contact with. So this is also one way to do the prevention, because if we treat the patient, we can prevent others from having the infection, requiring the infection from the patient. So this is also one way of preventing in the infectious diseases and its entire hierarchy. If we treat the reservoir, we can treat the transmission of infection. And finally, the behavioral and structural practices are, and these modifications are to be done. So using condoms and safe sexual practices can also prevent HIV transmission. And needle exchange programs, like you can do seminars and you can do webinars on needle stick injuries and how we can prevent it. You can teach the SOPs to the medical students, which is being taught at wards, how to handle the needles and how to handle the injection needles. and injections after doing an intervention on the patient. So this was all about HIV from today. So what we have learned from the session, we have learned about the modes of transmission and how we can use this knowledge to prevent, and we can spread awareness among the individuals that, and especially the medical students who are or we can say the medical personnel or the surgeons who are a very high risk of acquiring this HIV infection. We can teach them about the pre-exposure prophylaxis and about the needle exchange programs. We can give them information on how to prevent needle stick injuries, and we can give them information about the post-exposure prophylaxis that it exists. And if even if we do not have vaccination, we have the drugs to stop its replication, which is a post-exposure prophylaxis. And finally, we can give knowledge to the general population you have to do safe sexual practices, use condoms and other barrier methods as to prevent the exposure of these harmful viruses. So that's all from my side. I would be very happy to take questions from you.
Thank you so much, Hamza, for such an insightful, evidence-based, and enlightening session. Your explanation truly helped break misconceptions related to HIV and AIDS and highlighted the importance of public health awareness. Before we move towards the question answer segment, I would like to remind everyone about the verified e-certificate and quiz policy. अपना वेरीफाइड ई सर्टिफिकेट हासिल करने के लिए आपको 5 में से कम 4 सवालों के जवाब देने होंगे। क्विज का लिंक यूट्यूब वीडियो डिस्क्रिप्शन में अवेलेबल है और अगले 24 घंटे के लिए अवेलेबल रहेगा। प्लीज मेक श्योर टू अटेम्प्ट इट विद इन द गिवन टाइम टू सिक्योर योर सर्टिफिकेट। Please stay with us till the end to ensure your attendance is recorded. So let's move towards the question answer segment. Hamza, the first question from our attendee is, what are the current strategies to reduce mother to child transmission?
Kindly, can you repeat the question?
What are the current strategies to reduce mother to child transmission of HIV?
Okay. Okay, so we have to reduce the transmission of like HIV from mother to the child. So basically, again, it is all about. So basically, you can use ART, as I have told in the lecture, that ART, the antiretroviral therapy, we can administer it to the mother. It is no matter what the CD4 positive count is, whether it is 250, 300, we have to keep the viral load as low as possible, because at any point if the viral load goes up, it means that the virus is moving in the blood and in the serum. As there is transmission of blood, there is actually a free flow of blood of the mother into the child, into the fetus during the development. So surely there is going to be a transmission of virus into the child, and it can replicate in the child, or we can say the fetal cells, like the fetal CD4 positive T lymphocytes. It can surely replicate inside of those cells. So we have to keep the viral load as low as possible. This is the only treatment method that is available. Moreover, we have to educate the mother about the complications of HIV it can have that can be there on the child. We have to counsel the mother. We have to counsel the mother for we have to counsel the mother then what investigations the child should go through, like what test the child should have when the child is born. And also we have to do a highly vigilant vaginal delivery, or any sort of delivery, what delivery method you're using, you should be aware of that, and you should consult a gynecologist. There is actually a multidisciplinary team approach, because the infectious department, the department of medicine, and the department of obs and gynae, they will all be involved. So MDD is very important for this sort of a case where the mother has HIV, and we have to stop the we have to prevent the transmission of HIV into the child, into the fetus, into the end during birth into the child. And we also have to consult a pediatrician. So it is a multidisciplinary team approach where everyone comes in, counsels about the complications. Everyone does their own thing about how we can keep the child safe from HIV. But majorly during pregnancy, start the ART. Start the ART with those drugs which are not teratogenic to the child, or those drugs which are not going to have impact on the child. So the heart regimen for an adult is different from the heart regimen for that of a mother, because we should not use those drugs which are teratogenic to the fetus, because even if the HIV is not doing anything to the fetus, we are giving drugs which can have a negative impact or teratogenic impact on the development and growth of the child, or the fetus. And more importantly, we can also counsel the mother on IUGR and preterm labor and even spontaneous abortion. We have to counsel the mother on that, because if the baby is not growing, the baby is having intrauterine growth restriction, then what is the point of completing the pregnancy? So we can halt the pregnancy before, and we can go into the medical abortion, and we can counsel the mother on abortion. So that is why every part of the medical team is important in this sort of a case. So it is a case of MDT, where obstetrician, pediatrician, neonatologist, perinneonatologist, as well as gynecologist, and even the medical specialist on infectious disease is very important. And this is how we can manage and prevent the transmission of HIV to the fetus from that of the mother.
And the next question is, what are the common early signs of HIV?
As I've discussed earlier, the most common signs of HIV are fever, flu, rash, and lymphadenopathy, which are very non-specific, and they can also happen in common cold or any other bacterial infection or any other normal viral infection, which is benign and is not so much hazardous. So these on the basis of these clinical signs, these early clinical signs, you cannot say whether the patient actually had, or the person presenting to you have HIV. But like, if a patient comes to me or a person comes to me with symptoms of fever, rash, and lymphadenopathy, I will never detect HIV like on the first go, because it will be on the bottom of my list of differential diagnosis. Uh, but these early signs are very important, because if the patient is having symptoms of if a medical student pinpointedly remembers about the needle stick injury that he or she had 2 to 4 weeks before, then I can have a clinical suspicion. But the symptoms are actually fever, flu, very non-specific, lymphadenopathy and rash, or other common cold, rhinitis, pharyngitis. The symptoms are just like these, which are very non-specific, and obviously we cannot have a suspicion of HIV on the basis of these symptoms only.
Thank you so much, Hamza, for your precious time. So before moving towards the end, once again I would like to remind everyone about the verified e-certificate and the quiz policy. To receive your verified e-certificate, you must pass at least 4 out of 5 quiz questions. The quiz link is available in the YouTube video description and will remain open for the next 24 hours after the webinar ends. Please make sure to attempt it within the given time to secure your certificate. Please stay with us till the end to ensure your attendance is recorded. Once again, thank you all for joining us today. Thank you to our respected speaker for contributing to this important cause. Let's continue to spread awareness, educate communities, and empower the healthcare system together. Have a great and a wonderful evening. Allah Hafiz. Take care.